Hey guys, welcome back to Friends Enemas. My name's Lindsay, and who do I have with me?
My name's Megan. I am a colorectal surgery registered nurse at the Cleveland Clinic.
That's awesome. And she flew out to LA with her mom to come be on the podcast, which I think is so sweet and so fun. I love that your mom came with you.
I know. I was like, hey, awesome. Let's make it a girls' trip.
Absolutely. Why not? And it's a quick trip, 36 hours?
Yep.
That's what your mom said. So I was like, wow, that is a quick trip.
We're going to make the most of it.
But they didn't get to see Kim Kardashian yet, which...
No.
Bummer.
I said, Mom, she's at Jeff Bezos' wedding.
She's not going to be over here, Mom. Maybe go to Nobu for dinner and maybe you'll see her there. Okay, well, before we get into Megan's story, I thought it would be fun to read a new grad embarrassing story together.
Yeah,
maybe a couple
get into
of them.
It.
Hi, Lindsay. I have a story about another nurse I worked with. I work in a CBICU, and we had a new nurse that was on one of their last weeks of orientation. They were going to place one of the disposable temperature probes on an awake and alert and oriented ×4 patient since they no longer had a swan, and the Foley temperature port wasn't working. We hear screaming, run into the room, and she placed the probe in the urethra on top of the Foley. We told her, pull that out immediately. Girl. Oh, or guy. No, it was a girl. Girl. So wait, am I getting this right? She literally put the temperature, from the little oral thermometer into the urethra.
That's what I'm getting.
And there's already a tube there, so you just stretch it. Oh, no. Oh, no.
I don't have words.
How did you get that far?
With that,
there really is no judgment.
No.
But I want to hear the thought process.
Yeah, right, exactly. Can you tell us?
Can you write in if you're listening?
Yeah, for sure.
Because poor thing's never going to live that one down.
No, never.
That's for sure.
They're going to be talking about her for forever.
She'll get a nickname for sure. But maybe it was something about the Foley temperature port really messed with her. And she's like, so this goes... But my thing is, if you've never seen that in nursing school, because I know you haven't.
I never did.
No. So why would you think that would be? You know what I mean?
Right.
We gotta learn our critical thinking skills.
Because you use that regularly.
Right. Under their tongue, if it's the one I'm thinking of.
So if you've seen it, it's probably not...
I don't think it goes there. I will say the first time when I was a tech and I was taking temperatures, I used one of those, right? And it wasn't reading, and it was under someone's tongue. It wasn't in their urethra. It was under her tongue, and it wasn't reading. So I was like, maybe it's this button. And I pressed the button that throws off the probe in her mouth, and she was like, and just looked at me. I was like, you know what? I'm so sorry. It's my first day. And she's like, I'm just glad you're being honest with me. And I was like, Then I realized that's not how that works.
That's hilarious.
Not as bad as this one, in my opinion, but...
No,
we've been there.
We listen and we don't judge.
But we will correct you. Because no. Anyway, this one says, I was a new grad in postpartum and I hadn't put in a suppository before. I had to give one to a mom and started to put the suppository in while it was still in the plastic packaging because I thought the packaging was dissolvable. Oh. It was quite painful for the patient, obviously. And once I figured out what I did, I discreetly took it out of the package and put it in normally. The patient fired me after, but since she was a problem patient, everyone, including the patient's husband, assumed she was just being dramatic and it wasn't my fault. Photo reference.
Oh, I use those. That's to put... I could not imagine.
And those are pokey.
Pokey.
That is poking up her butt. At least she realized,
or her vagina.
Yeah.
Because are you giving it rectally or are you giving it vaginally?
Right.
Ma'am, if you're putting that vaginally in a postpartum patient, you're...
Something's wrong with you. Straight to jail. That's crazy. I didn't think about that because I was like, yeah, what is she? We don't know what the med is.
Yeah,
I assumed it was...
It looks like a baclofen suppository,
but
I mean...
But what if it wasn't?
Right.
Girl. At least she noticed it, but it's funny because I don't think she told anyone what happened here. They just assumed the patient
because they just assumed that she was being the difficult one, which also, ma'am, come on. That's a postpartum woman.
Own up. Well... Megan's here. We did a little intro with her. Why don't you brief us on your nursing journey?
Okay.
Yeah.
So, I started as a PCNA at the clinic in 2018. I started in colorectal surgery. It was the first job that I could get into. I was like, okay, I just need a foot in the door.
Yeah.
I didn't really know what I wanted to do with my life, so I was just trying to figure it out. I stayed there for about 3 years. Then I went to psych, which was interesting.
Yeah.
I love psych, but I don't love the systems in place near where we are. And so I got out of it because it was really, really difficult to kind of just be in that cycle of you're pushing people in, you're bringing them back. You're pushing people out, bringing them back, pushing people out, bringing them back.
Yeah.
Then I got into OB, and that one just hit a little too hard, too close to home. I have endometriosis, fertility issues.
Okay.
I worked in kind of an area where we were getting a lot of drug addicts and moms that were leaving their babies, and I couldn't remove myself personally from and be like in a professional. So I removed myself from that, and ambulatory job opened up in colorectal surgery. I was like, okay, I'm going to take it. I graduated nursing school. Let me back up. I apologize. I started nursing school in 2019, so I was still in a PCNA at that time in the colorectal surgery department. I graduated nursing school in 2023, and my manager was like, do you want to stay? And I was like, yes, I want to stay.
That's awesome.
And she's like, okay, cool, you have a job.
Oh.
So I graduated in December. I took my NCLEX less than a month later, passed the first time, and then started my job like 2 days after.
That's awesome.
So it was amazing. Nothing really changed for me except for like procedurally I was able to do more. But yeah, I am. I'm going on my second year there. So
very cool.
Yeah.
Wow. Okay, so colorectal surgery, we were asking, my husband used to be an endo tech, I think. I might be wrong. But he used to clean the tools after they were done with them. Okay. But that's not exactly
like
the same.
SPD, almost like sterile processing.
Yes. Which I think is interesting just because, I don't know, I feel like we all have, if we've worked in healthcare, like the baby steps to nursing was just always a little bit different, but kind of all the same. What exactly do you guys do on the colorectal surgery? So
we have anywhere between 8 to 10 surgeons in clinic. We see their patients, we room them, we get their vitals, we take their history if they're new. Most of them are coming to us for surgical consults. Some of them are coming for like hemorrhoids or new rectal bleeding, and trying to figure out what might potentially be going on. So we do a lot of assessments and evaluations of the patient. Sometimes we'll do something called flexible sigmoidoscopies on our rectal cancers or anal cancers. We do incisions and drainages. We do ceton tightenings. So we deal with a lot of like butts and guts is what we like to call it. So yeah.
That's cool though. I mean, do you get a lot of GI bleeding patients?
We get a few, but a lot of times they'll see like our gastroenterologist, and then they're going to the
they're gonna need some blood. They're gonna need okay, very cool, interesting. Would you want to talk a little bit about the did you say L&D or did you say postpartum?
L&D.
L&D. Do you want to talk a little bit about that, or you want to?
Yeah, we can talk a little bit about that.
What part of it, because I kind of resonated with you when you said like professionally I wouldn't be able to keep my personal thoughts out of it. That's exactly how I felt too for PICU, and for I think L&D too. Whenever I was only in clinical there, like I only remember 2 specific shifts there for clinical, and both I was like, I don't want to do this. Check off my list. I'm over it. Don't want to see it. Don't want to do it. Now I think I could do it, but straight out of nursing school, not having a lot of education growing up about a woman's body. I think I was like behind a little bit, even though I was an adult, if that makes sense. And then I just wasn't prepared. I just was like, I don't think I could do that. But now working in the ICU, I think I could go back there and be like, okay, I know what to expect. But what exactly happened on there that made you realize like this isn't for me and I'm not going to be able to be my best self here?
Like I said, I was diagnosed with endo in 2020, and at that point in time, we were also, my boyfriend and I were doing like fertility testing. We know that endo can sometimes cause fertility issues. And for me, I was just kind of continuously seeing these moms leaving their babies behind to the system, and knowing that myself and so many other women out there that struggle with fertility issues or pregnancy loss or anything like that can't get pregnant, can't have kids, and then there's these women out here that are, you know, granted, addiction is a disease.
Yeah.
And I very much understand that. But I think for me personally, it was very hard for me to come in there and not feel angry towards these women and not be able to look at them as like a human being as well. Like, you're going through something extremely difficult, and leaving your child had to have been a really difficult decision. But for me, I just couldn't. I couldn't separate the two. And I knew, like, it's not healthy for me to be around these people and to be treating them differently because of how I personally feel.
Yeah.
And so I just chose to step away. And I think it was also hard too, just like being around babies all the time, you know, like, I don't know what my future is going to look like when it comes to that. And I think it made me want children more, but I just wasn't in like the headspace for that. So it was just like a combination of things, and just realizing that I couldn't be the best person for these moms and for these children, and so I chose to remove myself.
I think that's the reason I'm glad that you want to speak on it, because I think a lot of people go through that and then they blame themselves, weirdly enough, that, oh, I'm never going to be a good nurse, but that was a good nurse move. You know what I mean? Like, you know yourself best, and you know that taking yourself out of that area would be better for you and your patients. Yeah. And I totally relate to that, because that's exactly what happened to me with the PICU. Yeah. There was a certain case of a child that was left behind, and the PICU, so meaning he's not a baby, he was like 3, 4. And I was like, what do you mean that happens? Wait, what do you mean? And I understand, I don't know their story and how difficult of a decision that must have made. But that was the day I was like, nope, I cannot work here. And that doesn't mean that I think anything about PICU nurses that do that. I think we all just have like a special spot for us.
I agree. And I think that it takes self-awareness and self-respect to be a good nurse and to look at yourself and be like, I can't do that. And if I put myself in that situation, I'm not only doing a disservice to my patients, but I'm doing a disservice to myself.
100%.
So to anyone out there questioning themselves, I think you need to, you know, ask yourself the hard questions and make the tough decisions, because regardless of, you know, how tough it might be, you're going to find yourself in a much better situation.
Absolutely. That's cool. I have never had anyone on here like admit that, and I'm like, no, because I think we've all been through something like that before, and it's relatable. Yeah. So you told us a little bit about how you got into nursing, into your specialty. Did you always want to be a nurse?
No.
My people.
So, well, it's actually funny. I spent the first 3 years of my life in and out of a hospital all the time. Okay. I had kidney issues, allergies to a bunch of things. So I was like in and out all the time. And I knew I wanted to do something medical, but I didn't know what. And as I grew up, I was like, oh, I want to be a neurosurgeon. Like, out of nowhere. I was like, yeah, neurosurgeon sounds cool, you know. I graduate high school. I go to University of Cincinnati for a year as a pre-med. I'm just like, I don't know that I can do this. I don't know how people do this. One, I was so young. Yeah. And two, like, I wasn't like putting my full self into it. I was like, no. So I moved home, which is when I started working at the clinic. I was like, okay, let me see if I can like figure this out. And then I saw the nurses on the floor. I was like, you know what they do is pretty dang cool. And I kind of want to do that. Yeah. But I knew that I wanted to be somebody for other people that helps when they're at their worst, because I had so many of those wonderful people taking care of me when I was younger, and I just wanted to give back. Yeah. Yeah. I love that. I had a similar situation too. My dad was in a motorcycle accident when I was in 2nd grade, and he was in and out of the hospital for, I always get the
time wrong, how long it was. It felt like 2-ish years in and out.
It felt like forever, especially when you're young. You know?
Yeah, it feels like every day. But the nurses there, they were so phenomenal. The nurses and the social workers. There was a time where my mom always had to bring us. You know, she was like working as like a single mom, really, because of his wreck, and her bringing us in, you know, they would always say like, we don't really need children in the ICU, but she's like, I don't have anyone to watch them, they have to come. Which is a side note why I understand when parents bring their children to the ICU. I'm like, they must not have anyone to watch them. But the nurses and the social workers would set up arts and crafts for us in their break room, me and my sister.
Okay, that's the sweetest thing ever.
I know. And I was like then I didn't know any better, but now I could cry thinking about it. I'm like, they literally went out of their way.
Yeah.
And looking back, it was like supplies from the supply room, but like making arts and crafts. Like that's cool. That's so sweet.
I know there's some bad apples in this industry, but when you hear stories like that, those are the people. Those are the ones that you want to remember, and remember why you got into it and why you're doing it.
Yes.
Because that's amazing.
I know. And they went above and beyond.
On top of everything else, they're thinking of you guys because you guys are going through such a difficult time too.
Right.
I love that.
I know, it's like I'm like, that's so sweet. But I brought it up because I didn't always want to be a nurse either. But once I started thinking about it, I remembered them. And I was like, okay, I could do that.
Yeah.
No, I've actually never done that. Even though I've had children in the ICU, it just didn't come through my mind. But I hope I can eventually like do something for one of the families like that. Because it's like those little moments that stick with us, obviously.
They might, I love this quote. They may not remember your name, but they will always remember how you made them feel. And it's like things like this.
Exactly.
Did you ever take one of those tests when you were younger about like what career you should go into based on, okay. So my dad made me take one. And every time I had to have taken it 2 or 3 times because I'm like, this can't be right. It was like, do not go into healthcare. Do not go into healthcare. It wanted
Stay away.
To be a teacher or something else. But I'm like, here I am.
And you're still doing great. It's fine. Mine told me that I was going to be a veterinarian or like something in animal science.
Okay.
Which was originally what I thought I was going to do. And then look at me now, working with people.
Here you are.
And people can really irritate me, but like also like working with people is a double-edged sword. It could really be great, but it's also awful sometimes.
Yeah.
You know, it just depends on the person, but at the end of the day, you know, it is what it is. Do you see nursing being your forever job?
So I'm going to give you a little 411 here. I haven't talked to a lot of people about this, but I'm actually studying for the MCAT.
Oh, okay. So going back.
Yeah.
Okay.
After the trip that I took that we're going to talk a little bit about more here soon, the itch is still there.
Yeah.
And being in that environment and going through that with those people, it made me realize that like I have to at least try and take the chance and see what could potentially happen, because I don't want to get 10 years down the road and wonder if I could have done it.
Yeah. That's really cool. For those that don't know, what's the MCAT?
So it is the test that you take to get into medical school. So it's like the entrance exam. So like anyone that was trying to get into nursing school, like the HESI test, this is just a much larger version of that.
Yeah, that's awesome. Well, speaking of the trip, because that's what we were going to get into next, tell us about it. Brief us on it.
Okay, so I joined Campaign 52, which is a multinational, multidisciplinary team that does humanitarian work in Eldoret, Kenya at GynoCare Women's and Fistula Hospital. That's run by Dr. Mabea and his local staff. And we go for 1 week of the year, and our goal is to give back hope, dignity, and a better future to one woman for every week of the year, hence Campaign 52.
Oh, cute.
Yeah. And this year, we really blew our goal out of the water, and we not only surpassed that 52, but we almost quadrupled it.
Oh, my God.
I think we did quadruple it.
Okay, so what exactly do you have to do to hit the 52?
So we have to perform 52 like operations.
Okay.
Yes.
Okay.
So what we do at GynoCare is we help perform fistula repairs for women suffering from obstetric fistulas, or like HPV screenings, colposcopies, things like that. So yeah.
That's crazy. And you quadrupled it.
Yeah.
Almost.
We hit 212 cases.
Oh, that gave me chills, actually.
It's actually mind-blowing when I think about it.
Yeah. What do you have to do to get into a position like that? How did you learn about it?
Yeah, so 2 of the surgeons that I work with went in 2024, and when they came home, they did a presentation about it.
Oh, cool.
And I've always known that I wanted to do humanitarian work. Like, something about it is just, I've always just been drawn to it. And when they did the presentation, I was like, this just feels right. Like, with the career that I'm in, being in colorectal surgery and this being geared to like pelvic disease,
yeah,
it was like, I have to put myself out there. They hadn't taken a nurse that year.
Oh.
Taking a nurse wasn't in the conversation, but I was like, hey, I'm really interested in going. If you guys are considering taking a nurse, please reach out to me so we can have a further discussion about it. That was in April of 2024. November rolls around, I still haven't heard anything. So I'm like, okay, like they've either decided they're not going or they're not interested in taking a nurse. And then like middle November shows up and the surgeon approaches me and she's like, hey, are you still interested in going? And I was like, yes. And she goes, okay, great. We want you to come with us. And I'm like, what?
Oh, that's so exciting.
So that happened. I met with the leader of the campaign who kind of put everything together. And he's like, yeah, we would love for you to join the team. We don't really know what that will look like right now, but we're going to try and figure that out. So that happened. And then we kind of just hit the ground running because April was like right around the corner.
Yeah.
So
that was this April.
Yeah.
Just a
so
few months
I went
ago.
in April in 2025.
Oh
yeah.
my God.
So this was the second year that they did the mission.
Okay. Take us through a day in the life.
Whew. So we worked 7-12 straight. Sometimes they were 13-14 hour days. Yeah. But like you honestly, like I didn't really feel it until it was over. You were just going. So we would get up between 5:30 and 6 every morning. We would go downstairs, eat breakfast. We'd get in these huge vans and we'd drive about 20 minutes to the hospital. And when I tell you guys, I had to take Dramamine every morning because the road to the hospital, like you were like this the whole way down this road. And we were teasing because pregnant women travel down this road to get to the hospital, like on motorcycles or walking. We're like, how do these women even make it without like delivering halfway down?
Oh, yeah.
Yeah, crazy. But so we would get to the hospital, we'd change into our scrubs, and then we'd kind of have like a debrief in the morning. So each person was assigned to either an operating room, a colposcopy room, or rounding in the wards.
Oh, wow.
I was kind of utilized all over the place. So I usually started my morning in the ward so that I could round on post-operative patients, do wound care, ostomy pouch changes for people who needed those. And then I would get called to the OR. I would get called to clinic to see patients that were coming in to determine if they needed surgical intervention or not, or whether we could send them home or whether we needed to send them to another facility for further testing. Then around like 1-ish, we would eat lunch, which was really neat because the hospital like cooks everything for us, and most of the food came from Dr. Mabea's farm.
Oh.
Yeah, so really amazing and fantastic. So that was so
cool.
fun. And after lunch, you just kind of pick off right where you left off. So I'd either be in the OR or rounding again or back in the clinic. I was just kind of all over the place. And then we'd finish the day by going through, I created a Word doc so that we could keep track of everything because documentation over there is very limited.
Really?
Yes. Like you're praying that you have the right person.
Oh, wow.
Yeah.
Interesting. I was going to ask about that in a second. Interesting.
And then, so you'd update it, like their post-op day 1, post-op day 2. These are the interventions. This is how long the Foley's staying in, so that everybody that's rounding the next day knows exactly what the plan of care is. So that Word doc would get updated every night, and then the surgical board for the next day would be updated that night and sent out to everybody and like where they're going to be and things like that. And then we'd pack back up in the vans and we'd go home and we'd do like, most nights we'd do a team dinner, but like sometimes we would like eat alone, but we'd probably be in bed by like 9:30, 10 o'clock and then starting
all over the
day
next day.
all over again.
Wow. Yeah. So what are, I wanted to ask what the major differences are between a hospital like there versus one here.
Yeah. So gyno care is tailored specifically to fistula care. So A huge difference is that anyone that needs higher level care, like we had an obtunded patient that we thought was suffering from aspiration pneumonia, possible stroke. We had to send her out to another facility because we don't have the resources to take care of her there. There is no on-site imaging minus ultrasound. So any sort of imaging that we needed for these patients, they had to go to another facility.
Oh, wow.
There's no pathology. So any pathology that we're taking in these procedures and the colposcopies, things like that, those are also getting sent out. So you could go 2-3 weeks a month without having results to these tests. I had to do a few large volume enemas, and I really had to like scramble to like get supplies together and do them because there's no large volume enemas there.
Oh, wow.
The charting is very different. So they have an electronic service, but like it's very basic stuff that you're like putting in the chart. A lot of it you're relying on paper charts.
Oh, wow.
And they have the patient's name written on them and their date of birth. And then they're put on the beds in the morning before you start rounding. But like we've had instances where they're not the right people. Sometimes 2 to 3 women share a bed at a time because that's how limited space we have. But that's how badly these women want these procedures.
Yeah.
And so you have 3 charts in one bed with 3 different women. And most of them speak Swahili, some of them speak English, but if they speak English, it's very broken. And so you're relying on the fact that these people know their names and know like a decent amount of their history and things like that, which is not always the case. This didn't happen when I was there, but the year prior, they did have an instance where they brought the wrong person back to the operating room.
Oh, no.
And they caught it. No, they caught it, but it happens.
Yeah.
So next year we're working on like patient wristbands and things like that. But there are a lot of differences. I mean, the ward in specific, you would never see 2 to 3 people in a bed here in the U.S.
Yeah, no.
Never.
No. They would be in the hallway maybe.
The operating room looks like it's straight from like the 1950s, 60s. No sheets get laid out on the beds. Like it's just the patient laying directly on the surgical bed, and those surgical beds get like quickly cleaned down. But like HIV patients are laying on those beds. Non-HIV patients are laying on those beds. It's very different.
Yeah.
But
they're working with what they have.
Exactly.
And providing care the best they can.
The resourcefulness that I saw while I was there. Because you ask yourself, how did you do this before we came along? Yeah. But Dr. Mabe and his team have been doing this since 2011.
Oh, that's crazy.
And they have operated on more than 800 women.
Wow.
So it's like, you guys have been doing this far before we came along. Yeah. And now we're trying to help make advances in that. But it's just amazing to see what they're able to do with the things that they have. Like you would never know that they didn't have the things that we have. It's just how they function and how they operate. It's mind blowing.
Yeah. It's really cool. I mean, like you said, they're working with what they have and they're doing the best they can with it as well.
Yeah.
That's actually really cool.
Yeah.
Does this, what's it called again?
Gynocare?
The project.
Campaign 52.
Campaign 52. In my head, it was Camping 52, and I was like, that doesn't sound right. So Campaign 52.
Yes.
Is there a need for other people to go with them, or do they need anything besides like funding?
So we definitely need equipment. We're trying to get like lists together of like specific things that we need. We are looking for a wound ostomy nurse to come along, but I know that there's a bunch of people that are interested. So I know come August when we start talking about things, we'll bring that back up. But I don't know that we're necessarily looking to expand the campaign itself. That if people are interested, they can reach out via the social media, and we can definitely run that by the leader.
Yeah. I just was curious because I know people will be asking.
Yes, of course. No, you guys can for sure reach out. And we can have that conversation come August, because who knows? I mean, more hands the better.
Yeah.
Especially from a nursing standpoint. I was the only one last year.
Yeah, that's crazy.
I would love to have some nursing friends with me. But yeah, they can reach out on social media, which I think will be linked.
Yes,
down
it will
below.
be linked here too.
So, yeah.
So going back to you going there and potentially, or essentially you're doing like rounding, not like getting a report from anyone like you would in the day shift, night shift. You're just rounding on these patients who have already been there. Interesting.
Yeah.
Okay.
And like going by the notes that I had on these patients from the day prior.
Yeah.
So like a lot of times, because I was rounding, I would be the one helping to update the Word doc. So I would go in and like by day 5 or 6, I was pretty familiar with the patients, but it was still like, okay, I gotta double, triple check.
Yeah.
So like I'm reading through my own notes, like making sure that like
on your Word doc.
Seriously. I would carry my computer around like this.
Oh my gosh.
And sometimes I would like type like this with my thumbs.
Oh my gosh.
Yeah.
That's so interesting. Very cool though. What a cool experience. And like, what has it done for you?
It's changed my life. It's given me a completely different perspective on healthcare. And I don't want this to come off the wrong way, because U.S. medicine is completely different. But like, these women spend several days in this hospital waiting to have surgery. Some of the women that come into the clinic spend 12 hours waiting to be seen to even determine whether they're going to be admitted or not.
Wow.
And they don't say a word. They don't ask multiple times when they're going to be seen. They just sit there and they wait. And then they thank you over and over and over and over again for what you're doing for them. And it can make me cry. Like, just thinking back to how grateful these people were. And it's like, I feel like I'm not even really doing that much for you. Like, you're sitting here for all of these hours. And I think sometimes we forget like how privileged we are here to have such quick access to medicine. Like, some women traveled 5+ days to get to us to have surgery. And while, you know, some people may choose to travel to different facilities for different care, there are so many hospital systems here, and we don't really see that, you know. And they're walking for several days, they're taking buses, like they don't have money to transport themselves, and so they're getting by any way that they can. And so I think it really just gave me a mindset shift in how I view things and how I see medicine here. And one of the people that went in 2024 said, I view my life as before Africa and after Africa. Aww. And I was like, I wonder what that's going to look like for me, you know. And it's very much that, like, I see the Megan that went to Africa, and then I see the Megan that came home from Africa. And I had some pretty profound experiences. We experienced really dark things, and, you know, we're dealing with very heavy stories and things that these women went through. And it's sobering in a way, you know,
it gives you perspective. I always say perspective is key with everything, and like, you don't know what someone's going through unless you've been there with them or seen them or touched your foot in just like a tiny bit of their space, you know. And I feel like I'm so happy that you wanted to talk about this on here, because sometimes I think missions trips get a bad rep. Do you know what I'm talking about? Like, and it makes me question things, just because I'm like, well, the message and the goal is to help others. Like, what's so bad about that? Right. Without bringing politics or religion into it. My husband, actually right before I met him, 2 weeks before I met him, he was on a medical missions trip in Mexico. And he talks about some of the same things. I've never been on one, but I want to go on one at some point. But he talks a lot about how before he went versus after he went, and how you just realize how other people deal with tragedy, and they do it the best they can, and it is the best that they can. Like, that's what they do. But then you reflect back to what we do, and kind of like how we complain about certain things here, and you're like, not because pain is relative, I understand, but like, some of our complaints are silly.
I was on another podcast actually with my friend Lexi, and we talked about this. She has a chronic illness podcast, and living with chronic illness most of my life, like I've been in that, I don't like to call it the victim mentality, but like I've been in that victim mentality where it's like, you're like, why is this happening to me? And like, why can't I get out of the cycle? And, you know, and we talked about this and how it going there put into perspective for me, like how I can adjust my thought process when I'm in those really difficult and bad days. Yeah. Like, how can I make myself feel just a little bit better? How can I be just a little bit more positive about the situation? Things are going to suck. Yeah. Life sucks sometimes, and it's not a competition. But it's also okay to realize that, you know, we don't have to constantly be the victim to our lives. Our lives are happening for us and not to us. And I think that those women really, really taught me that.
Yeah, that's really cool. Yeah. Are there any stories that like specifically that you feel comfortable sharing? Like, yeah? Okay.
I have two that really, really, really stick with me.
I can't wait.
So one of them I was not directly there for, but all of us in the group felt the heaviness of this. So there is no reimbursement at hospitals in Africa for childbirth. So a lot of times they have to charge for the deliveries.
Okay.
And we're talking people that live in tin huts with dirt floors, no running water, no electricity. They're wondering where they're going to get their food from the next day. And they're having these, so shillings is Kenyan dollars. So 15,000 shillings, which would be $100 here. So to us, $100 might not seem like a lot of money, but to them, that's like months worth of food, water, whatever it may be. And we had this mom 2 days postpartum whose husband left her with their other child. And she had this $15,000 or 15,000 shilling payment to make to the hospital. And she's like, I can't do it. And she went up to the rooftop and she was going to jump.
Oh my God.
And take her life, and leave her newborn baby behind. But for them, that's the only way they see out of it sometimes. Like she literally was talking about, I don't know where I'm going to get the food. I don't know how I'm going to make ends meet. And the hospital ended up covering the bill for her, because they're just absolutely amazing like that. But it was shocking to realize that that's the situation that most of these women are in. Like, they can't put food on their tables, and she was so desperate and didn't know how to move forward, and she wanted to take her life because of that. And it shook all of us.
Yeah it was
really difficult,
deep story.
So that was one that will always stay with me, again, because it gives you a perspective into just life for them.
Absolutely.
And how resilient they have to be all of the time. And another one, not as heavy, but still sad. A 3-year-old comes in with bladder exstrophy, so her bladder is on the outside of her body, and she had no anal opening due to congenital malformation. So she had an ileostomy, and I was called to clinic to pouch her ileostomy, but I did not know what I was walking into. I was just asked to go in and pouch. And I go in there, and I'm like, okay, you really have to pull yourself together. Like, I was devastated seeing this. Like, that was my first time ever seeing a bladder exstrophy. I was like, whew.
I'm trying to picture it too, because I've never seen anything like that.
It's literally just the bladder sitting outside of the body. So, like, it's just open to air. And, again, they don't have money for supplies, so baby just has a diaper on, and her skin is completely excoriated. I was like, I don't think I'm going to be able to get a pouch on this. Like, her skin is awful. So I'm doing my best, and she's, crying because it hurts. And I'm like, oh my gosh, I don't know if I can do this. I ended up getting the pouch on. I let her play with my badge reel as I was like finishing up. So like that was cute. But I got her down off of the table and she just immediately starts running around and she's laughing and giggling and like holding my hand. And I'm like, okay, you are precious.
I was gonna cry. That's so sweet.
And you have all of this going on and you're still just this bright light,
like vibrant. Yeah.
So we ended up admitting her and she underwent 2 surgeries with us. So we did an EUA on her just to figure out, which is an exam under anesthesia for anyone not familiar with EUA, just to kind of figure out what our plan is for her. And then on our last day there, she underwent this like 8-hour operation. And I'll never forget, I got to carry her into the operating room. And sorry.
It's okay. I should have had tissues. I didn't think about it.
She's obviously upset, not understanding what's going on. And I was singing her "You Are My Sunshine" until she goes to sleep. And I had people keep me updated because I just couldn't go in to the OR. I just like couldn't handle seeing her that way. But they ended up completely excising the bladder, and they were able to find both of her ureters. So they gave her an ileo conduit, which was awesome. So she'll go to the bathroom into a pouch, urinate into a pouch for the rest of her life. And then they just revised her ileostomy. But at the very end, they're like, do you think you can handle like pouching her for us? Because no, we're not comfortable with anyone else. I was like, that's fine. I think I can do that. So I go in and I pouch her, and I'm there as like she's starting to come out of anesthesia, and we move her into recovery. And then I got to go with the surgeon to update the family, and that was really hard because even though they were kind of like briefed on the fact that she would probably end up with 2 ostomies, like nothing can ever prepare you for that. And there's a lot of stigma in Africa around these diseases and conditions. And so, their first thought is, what is her life going to look like as she gets older, reasonably so. And so you just have those conversations with them, and they came around, and it was just, I don't know. I remember we had our closing ceremony that night, and I come back upstairs before we were leaving officially for like the last time, and they're getting ready to take her back downstairs. And I just like ran over to her aunt. So her aunt and her grandma are taking care of her because her mom decided that she didn't want her anymore after she was diagnosed with all of this stuff. So her aunt and her grandma are her primary caretakers. And I just remember hugging the aunt and just being like, you guys are going to be okay. Yeah. She's a warrior. She's going to be okay.
Yeah.
But I think about her often. I get updates from the staff, and she's doing well, running that's around good. And
that's good.
Being her sweet little self that I remember. But it's just, you're like, these women go through so much, and yet they still have a smile on their face.
Yeah.
And you would have never known, like if you had just looked at her in general, like you would have never known that she was going through everything that she was going through.
Yeah. And you got to be that person too, it's like you developed like a good rapport with these people too, mm-hmm. and you got to like see them transition throughout their time at the hospital.
Yeah.
Trigger warning for this next segment, you guys. It contains graphic discussion of childbirth trauma, including references to mutilated and deceased infants due to lack of medical care during delivery. This content may be deeply distressing to some listeners, so please use discretion and skip ahead if you need. The stigmas on the, I guess, pouches in general, or those types of diseases, is it more so they don't look physically like they should, or do you know?
So it's a lot of things.
Yeah.
This is actually a conversation that I want to have because this is a huge part of why there's such a large issue over there with female pelvic fistulas and obstetric labor and things like that. There's a lack of education. There's lack of access to health care. And then there are stigma and cultural and societal things that all play a role into this. So I'm just going to give a little bit of history so that people can kind of have a little bit of an understanding. So 64% of births that happen in Africa are attended to by healthcare professionals. So whether that's a doula or like a midwife, a nurse, or a doctor.
Okay.
And when you get into more like Sub-Saharan Africa, where there's like smaller villages and you're way more spaced out from facilities, that number decreases significantly. Mm-hmm. So a lot of women are delivering babies without healthcare professionals, and they're having obstructed labors. So baby gets stuck for several days.
Oh, wow.
Baby ends up passing away. They have to basically like break baby down in order to get baby out.
Oh, wow. But
at that point, mom has already suffered significant trauma to the pelvic region. So most women end up with a VVF, which is a vesicovaginal fistula, so an abnormal connection between the bladder and the vagina. So they leak urine constantly out of their vagina, and it like doesn't stop.
Oh, wow.
Or they get rectovaginal fistulas, which is an abnormal connection between the rectum and the vagina. So they can leak stool out of their vaginas constantly. And with this, there's odor, smell. They're not looked fit to be married or to have sex with or to carry babies again. And so a lot of times they're kicked out of their homes, they're left by their husbands, they're exiled from their communities, and they're basically just like left to fend for themselves.
Wow.
So there's this stigma that exists that if you get a female pelvic fistula or you end up with one of these conditions, that you've sinned or you've done something wrong, or, you know, you're just not a good person.
Wow.
And it's very unfortunate. So kind of going back to like the obstructed labor and things like that. Like I said before, many women are 5+ days away from hospitals or whatever the case may be. So it's unfortunate. And there's 50, according to WHO, there's 50 to 100,000 female pelvic fistulas yearly.
Wow.
But in Africa alone, there's 2.5 to 3 million women suffering from female pelvic fistulas.
Wow.
So it's a major, major issue. And these women will go years without help because of lack of knowledge and the feeling of isolation. And, you know, a lot of these women can't have jobs. Like I said, they get disowned by their families. It's really sad. And they aren't prioritized from a nutrition standpoint. So they're not getting like proper nutrients. Men are prioritized with food. So like they're not getting proper folic acid. Environmentally, they're being exposed to a lot of things. So like just in general, like women there are just not respected and looked at the same way that men are, and in a very drastically different way.
Yeah. And
so it's really, really sad. So even with like ostomies, you're not viewed as married status, or you can't have sex, or you can't have babies, which we know those things aren't true. Like people have sex and have children with ostomies all of the time, but that's how they view things. And sex and marriage are very important in their culture. Mm-hmm. We actually, unfortunately, see a lot of women come back to gyno care because they have sex far too soon, because their husbands will not wait.
Wow.
So they have this operation, they go home, their husbands want to have sex. And I remember several of the doctors saying to women before they were being sent home, you cannot live with your husband. Like, you have to go live somewhere else, and you cannot have sex for 3 to 6 months.
Oh, wow.
Like, you cannot. And so it's like, this is the reality that they're living in. Like, if they can't have sex, if they can't bear children, like, they're useless.
Wow.
And most women, after these severe female pelvic fistulas and obstructed labors, it's very hard to have successful pregnancies and births and lives after the fact.
Yeah.
And so it just makes for a really difficult living situation for them, and it's devastating.
That
And they
is so
suffer for years and years and years and years.
That is so, so sad. Do they ever come together with each other? Other women?
Yes. So actually this year there was a group of 4 women from Somalia that were all brought over together. So that was really great.
Yeah.
They all had each other.
Yeah.
So that was really, really nice. But other than that, I don't remember like many
doing that.
Yeah.
That would be cool for them to realize none of that is their fault, obviously, right. Which we know, but it's probably really difficult when your whole society thinks, for the most part, thinks one way.
Yeah.
And then you are just brainwashed in a sense.
So another thing that's still very prevalent there, although it's been banned since 2011, is female genital mutilation. And female genital mutilation can lead to worsening of like obstructed labors, hemorrhaging, infection. Like these women are being exposed to very harsh and very horrid circumstances. And you know, I had this conversation with a coworker and they're like, I just don't understand. And it's like, it's not for us to understand. This is their culture. This is what they've grown up knowing. They don't know anything else.
That's their own bubble.
Exactly. And a lot of times, like even if we have a mutilated genitalia from women, like they won't talk about it because they know how people view that and they know how people view them, which is really sad because in medicine, we want to create safe spaces for our patients, right? And so them not even being able to have that conversation is devastating because it's a huge portion of their life and it's part of the reason why they're experiencing what they're experiencing now. And on the campaign, social media, we're actually working right now to get 7 women's stories up on there. We interviewed some women while we were there, which was great. And one of the women shares her story, and there was a lot of abuse when she was young, and she was raped by 4 men, and that's just like the sort of stuff that you see that's just like normal for them.
Yeah.
Like being mutilated is normal, and it's like I said, it's not for us to have an opinion or a judgment on, but like it is our responsibility to be there for them if they want to talk about it, and to be there to remind them that it's not their fault and that they have the right to heal from that trauma and that pain. So it's just, there are so many things. Like I'm just touching the tip of the iceberg with this conversation, but these women, they really just, they go through so much, and yet they're the most brave, resilient, kind, loving people that you will ever meet in your life.
Yeah. Wow. I mean, I almost don't even have any words just because it is a lot. It's a lot to take in. And strangely enough, I feel like I knew some of this. Well, I had heard some of this stuff before, but I didn't know how true it was because I didn't have any direct resource, if that makes sense. So thank you for speaking on that. Something you were talking about that threw me back into when I was a new grad was you named it correctly. I just knew it as just a regular fistula in between the vagina and the...
Yeah, a vesicovaginal.
Yes.
Yeah.
I had a patient with one of those, and no one knew. I was freshly on my own. I was cleaning her, and I was like, I swear there is poop coming out of her vagina. But I kept cleaning her, and I was like, no. Cleaned her up. Came back, it was still happening. So I went and told the doctor. He said, that's not possible, that's not happening. I was like, I swear it's happening. He just was like, you cute little new grad, get away from me type thing. And I was like, I need you to come look because I've already cleaned her multiple times and it is seeping out of her vagina. I had never seen it before. Lo and behold, she had a fistula there. And I was like, I had no clue that it's real. And so I was like, first of all, good for me, because I was like, no, that has to be some type of hole there. I don't know what it is. I've never been taught that, but it's real and it happens. And he was like, real. My bad. Yeah. My bad.
And it happens here in America too.
It does.
We see it all the time in colorectal surgery specifically because it's a pelvic issue, especially rectovaginal fistulas, VVFs. We typically do combo cases with urology, and gyne, but rectovaginal fistulas, we see them all the time. It's just the more you know. Different reasons. Yeah. But yeah, the more you know. I mean, good for you for like calling it out. But like, seriously, that can't happen. This is something that bothers me so much, and I'm getting a little off topic here, but we're all people and patients are not textbooks. It drives me nuts. You cannot treat everybody the same.
No. I was like, girl, talk.
Just because you cannot see it does not mean it is not possible. And this is something that I have to fight for all the time with living with invisible chronic illnesses. It's like, okay, this may not be something that you've seen before, but it doesn't mean that it's impossible.
Yeah.
And it doesn't mean that just because this person didn't present the same way or this person didn't present this, you're not going to have textbook patients. So stop treating us that way.
Exactly.
It goes everywhere.
Yeah.
Not just here.
Yeah. No, I love that. I'm like, girls, scream it because I totally agree.
And just because doctors really need to get off their high horses.
Yeah. And this guy was one of those people where I was like, I wish it could have been a plethora of other doctors that I knew would have taken me serious right away.
Yeah.
But this one, I almost knew he wasn't going to take me serious, but I was like, no, I swear something's happening there. I don't know what to call it, but something's happening.
Nurses spend 75% of the time with patients.
So if I'm saying something's happening, it's probably happening. It is happening. Just believe me.
Get in there with a flashlight and look for yourself. I'm telling you.
That's what we had to do. I was like, come look for yourself then if you don't believe me. Because, like, I don't know what else to do, but that can't be normal. Something has to happen for her. Yeah.
Like, sir, you work in medicine. Anything is possible.
Thank you.
They do brain surgeries with people awake playing guitars. And you mean to tell me that somebody can't have an abnormal connection between their rectum and your vagina? Get out of here.
Yes, exactly. Exactly. Very frustrating.
Oh my God, that's crazy that you got to see one.
I know, it is great. I've only seen it once though. So when you said that, I was like, oh, I know what that is. So you said you wanted to mention something?
Yeah.
I forgot.
So all of the operations done at Gyno Care are free. So like they perform these fistula repairs for free because they know that there's such a need for them. And that there is such a lack of funding and resources available to these women that the hospital pays for everything.
That is crazy.
When the campaign comes on, we do like a GoFundMe to help. What that GoFundMe does is it helps with equipment and it helps for us to be able to transport people from their villages to the hospital and then back again. So the social workers at Gyno Care, they're absolutely phenomenal. Like the care coordination that happens at this place is absolutely amazing. But like they set all that up. So they go out to these villages. They look at people. Like they get them on their kitchen tables and determine whether they're a fit to have this procedure done. And then they bring them in from the villages to have the surgery. And they set them up with their supplies once they're discharged and things like that. And so the funds go to
the patients, truly.
Everything that we do for the patients.
So it's free. Where does the hospital get the money, though? Donations, I assume?
Yes. So the hospital has a donation page directly on their website, which will also be linked in the description. And then Campaign 52 has a GoFundMe as well. So either one can be donated to.
Very cool.
Yes. So any funds are greatly appreciated because they literally provide life-saving surgeries for these women.
Wow.
Yeah.
What you said there was something else you wanted to leave with.
So as we were kind of talking about these women and how they get shunned from their communities and they get disowned by their husbands, people might be wondering, okay, so what happens after they have the surgery? Like what happens to them?
Yeah.
And Beyond Fistula, which is a nonprofit organization that was started by an OBGYN in 2012, helps to reintegrate these women back into society. So after they've had surgery, what they can do is they go into like trades, so they can learn how to sew, they can learn agricultural skills, they can go back to school for certain things, and Beyond Fistula pays for all of that. They live in house at Beyond Fistula, they cook, they clean, they do daily activities. There's kids that live there as well with their moms or sisters or whoever it is that's a patient there, and they basically help them to get back onto their feet by providing them with a skill that will allow them to earn money for themselves. Oh. And they also host like group and individual counseling so that people can have mental health support as they're learning how to navigate life post-surgery and post-fistula repair after having these issues for years and years and years and years. It takes a lot of work to help these women get back into society. So Beyond Fistula is another program there that is just absolutely amazing. Yeah. I got to come home with so many goodies from the girls that sew. I got a backpack and some toiletry bags, which I actually brought one with me, so I'm really excited about that. But it's just from start to finish, every piece of this hospital and the things that they do for these women is absolutely amazing. Dr. Mabey and his team, when we're not there, they're still operating. They've been operating since 2011, and they're going to continue to operate when we're not there. I'm super thankful to be a part of Campaign 52 and the work that we're doing, but we're just a small part of that. We're there for 1 week. Dr. Mabey is doing this for the 51 weeks outside of us being there. And it's just truly amazing the work that him and his team are doing for these women. And if I can leave you guys with anything to remember or to take away from this, it's that me being here and talking about this with Lindsay is important because these women need a voice and they need to know that they're being heard, that they're being seen, and that people care about them. All these women want is hope. Mm-hmm. Hope that there's a different life ahead for them and hope that there's a better future. And that's exactly what Campaign 52 and Gyno Care attempt to do, is give back that hope, dignity, and a better future to these women. And, you know, I know I mentioned funds. If that's not something you're able to do, share this with somebody, this episode, and educate people about what's going on out there. If you know companies that would be willing to donate ostomy supplies, wound care supplies, surgical equipment, reach out to us. Yeah. We could use anything and everything that the people can offer. But yeah, thank you guys so much for listening. Lindsay, thank you so much for having me.
I'm so happy you came on because, like I said, I didn't know a lot of this. So it's really educational. It's inspirational. I love stories like this too, because once again, it brings perspective back to us again and again. Yeah. So thank you for coming. Where can everyone find you if you want them to, and where can they find Campaign 52?
Yes. So Campaign 52 can be found at campaign_52. That's on Instagram and Facebook. And then myself, I can be found at Megatron.
That's cute.
Yeah. I was a bodybuilder in high school, and my best friend was like, "You're kind of like a transformer." So he gave me the nickname Megatron. But it's MEGAATRONN__.
I love that. Awesome. Okay, well, we will put those socials in the description along with the website, the donation links, etc. Once again, thank you so much for being here. If you guys are still here, make sure you follow or subscribe to the podcast. It really helps push it out to other people just besides us. And that's all for now.
That's all.
All right. Bye, guys.
Bye.